sustained injuries on his dirt bike. He reports that when landing the bike after a jump, he lost his seating and suddenly straddled the center bar of the bike, which resulted in severe pain between his legs. Okay, for 15 minutes after being injured, he was unable to walk. He has had similar accidents twice in the past, but the resulting pain was not as prolonged and severe. The patient is in distress, pulse is high, respiration normal, BP super high. Exam shows laceration and ecchymosis over the face and hands. Visual exam of the scrotum shows diffuse edema and ecchymosis. The scrotum cannot be palpated because of the pain. Which of the following is the diagnosis? Oh, it's most likely to confirm the diagnosis.
Okay. Stratal injury. Stratal injuries can cause blunt trauma to the scrotum and testicles. Stratal injuries can cause blunt trauma to the scrotum and testicles, in addition to pelvic fracture and urethral injury. In addition to pelvic fracture and urethral injury, in this patient, the presence of edema and diffuse ecchymosis of the scrotum. Edema and diffuse ecchymosis of the scrotum is consistent with testicular rupture. Testicular rupture. Testicular rupture occurs when compression of the testis leads to break in the tunica albuginea. Testicular rupture occurs when compression of the testis leads to break in the tunica albuginea that tunica albuginea and may lead to expulsion of testicular contents. Other testicular injuries may occur because blunt trauma include hematoma, torsion, spermatic cord avulsion. The diagnosis can be established with Doppler ultrasonography, which is useful to identify the fracture plane within the tunica albuginea, assess testicular perfusion, and detect hematocele and or avulsion injuries. In case of suspected testicular rupture or testicular non-perfusion, urgent surgical exploration is necessary to repair the tunica albuginea, repair torsion or cortical intrascrotal hemorrhage. Adjunctive medical treatment includes analgesia, ice, scrotal elevation, and non-steroidal anti-inflammatory drugs. Although the prognosis is favorable with appropriate surgical repair, late complications include testicular atrophy and infertility. And transillumination is done for hydrocele. Palpation of the scrotum with anesthesia is not recommended. Aspiration is not recommended, and MRI of the testes may be helpful assessing testicular integrity in case of suspected testicular injury, in which ultrasonographic findings are equivocal but is not necessary in most cases. So, stratal injury, uh, Doppler ultrasonogram of the scrotum.
Got it. Next. A 12-month-old boy brought to the physician by his mom for a well child exam. His mother is concerned because she does not think he's gaining adequate an adequate amount of weight. His diet consists of cow milk-based formula and solid food. He has 4 bulky, light colored stools and 6 wet diapers daily. He's at the 10th percentile for height, 5 percentile for weight, and 75 for big head. He has had 3 ounce weight gain since his most recent visit 3 months ago. Developmental is appropriate for age. Exam shows paucity of subcutaneous fat, paucity of subcutaneous fat, and thin air, thin hair. Okay. Which of the following is the most appropriate
What
next
is
step?
your diagnosis? Just look at the stem, then you decide your diagnosis. I haven't found any, that's why I asked
I know. I'm like, I looked at
you.
oh,
If I know the diagnosis, then the test is easy.
Mm-hmm.
Like
Yeah.
in the answer, like perform sweat chloride test, uh, I can say it easily, but I haven't found anything to diagnose
Any
it cystic
flu, yeah.
fibrosis. There is no cough, nothing, pneumonia. Cystic fibrosis patient has like pneumonia feature, or there may be absence of vas.
Mm-hmm.
Pancreatitis may be one of the feature.
Mm-mm. Yeah, I don't see it.
He
I think
has
I just.
just only four bulky light color stool, like
Mm,
malabsorption, and six wet diapers daily. Okay, reading the explanation.
mm-hmm.
This patient presents with failure to thrive. This patient presents with failure to thrive, defined as persistent weight at or below the fifth percentile, persistent weight at or below fifth percentile for age and sex. Although a variety of definitions are employed, failure to thrive in an infant should prompt evaluation for underlying cause. Common causes include inadequate nutritional intake due to insufficient breastfeeding, inappropriate diet, poverty, neglect, malabsorption due to cystic fibrosis, pancreatic insufficiency, cow milk allergy, or gastrointestinal malformation, or increased metabolic demand due to congenital cardiac, pulmonary, or kidney malformations, hyperthyroidism, or malignancy. In this patient, paucity of the subcutaneous fat and thin hair, paucity of the subcutaneous fat, thin hair, and light color stool raises suspicion for Cystic fibrosis is autosomal recessive disorder caused by defect in the CFTR gene, leading to deficiency in chloride channel that secretes chloride in the lungs and GI tract, and reabsorbs and reabsorbs and and reabsorbs chloride in the sweat gland. This abnormal chloride transport causes decreased chloride and water secretion and increased water reabsorption, leading to abnormally viscous mucus. The thick mucus in the GIT contributes to pancreatitis, pancreatic insufficiency, steatorrhea, malabsorption, leading to deficiency of fat-soluble vitamin, headache. In the lungs, the disease manifests recurrent pneumonia, especially in the Staph aureus and Pseudomonas aeruginosa. Mm, Obstruction and destruction in the airways leads to hypoxemia, air trapping, and bronchiectasis. The absence of digestive enzyme. The absence of digestive enzyme made by the pancreas leads to malnutrition, cachexia, muscle wasting, weight loss, vitamin deficiency, and frequent loose stool, foul smelling, sometimes oily stool. Cystic fibrosis can present with meconium ileus and other cause failure to pass stool after birth. The diagnosis is established by sweat chloride test and confirmatory by genetic testing. Okay,
Can you read D as a dog?
yes. Performing barium enema. Perform barium enema is useful in the diagnosis for the congenital megacolon Hirschsprung disease, also known as intestinal aganglion- aganglionosis. This condition is caused by congenital absence of distal portion of the mesenteric plexus, results in mesenteric plexus presence with inability to pass the meconium in the first few days of life, eventually large bowel obstruction, and explosive expulsion of feces on rectal examination is a classic finding. This patient with a history of passing normal number of stool with conge- is not consistent with congenital megacolon like Hirschsprung disease. Okay,
Yeah. I think Hira just deleted the other ones and got to the answer probably.
yes.
42 woman comes to the physician because she had a 2 hour episode of shortness of breath yesterday after walking for 2 blocks. She has not had chest pain and has no previous history of shortness of breath with exertion at night. No previous history of shortness of breath. Okay. She has a 6 year history of fully controlled hypertension. Current medication is diuretic, beta blocker, and calcium channel blocker. There is no family history of coronary artery disease. Patient does not smoke. Pulse is fine, but an irregular respiration fine. Blood pressure is super high. Lungs are clear. On cardiac exam, S1, S2 are normal. No murmurs are heard. Serum studies show total cholesterol concentration is 130 and LDL is 90. Let me check. Where is it? Cholesterol is fine and LDL is fine. ECG shows AFib and left ventricular hypertrophy. Which of the following is the most appropriate next step in diagnosis?
Okay. So this patient with exertional dyspnea and poorly controlled hypertension, evidence of left ventricular hypertrophy on ECG, or evidence of left ventricular hypertrophy on ECG tracing, ECG presentation with new onset heart failure, hypertensive cardiovascular disease describes the pathophysiology of the heart failure. In the setting of poorly controlled hypertension, which generally begins with LVH caused by chronic increase after load, untreated LVH can lead to systolic or diastolic failure, which manifests symptoms shortness of breath, cough, reduced exercise tolerance. Echocardiography is the gold standard diagnosis. Echocardiography is the gold standard diagnosis for heart failure. Diastolic failure is characterized by impaired relaxation and chamber hypertrophy on echocardiography. Diastolic failure is characterized by impaired relaxation and chamber hypertrophy on echocardiography. Okay.
Yeah. Next.
Yes.
82-year-old woman admitted to the hospital because of a 4 day history of dyspnea, cough, productive of brown sputum, nausea, fever, and chill. She has hypertension, type 2 diabetes, hypercholesterolemia, medication, amlodipine, benzapril, atorvastatin. She has no known sick contents. 1 week ago, she returned from a 15-day vacation where she stayed in a hotel for 5 days and was on a 10-day Caribbean cruise. No smoking, alcohol or drugs. She lives alone and is able to perform activities of daily living without difficulty. BMI is fine. Temperature is a bit high. Pulse is high. Respiration high. BP is normal. Pulse oximetry is 89 on room air. Pulmonary exam shows dullness to percussion of the lower lobe of the left lung. Labs, glucoside count is high. Urea, I think it's normal, and creatinine is normal. Let me double check, but yeah. Oh, urea is a bit high, creatinine normal. Hemoglobin concentration, serum, electrolyte, and serum results of urinalysis are fine. Checks S-ray and gram stain or sputum are shown. Which of the following is the most likely infectious disease? Something you
What is the
infectious.
clue for strep pneumonia?
Oh, the Lancet J diplococci. You don't see it. It's like two, but like not really circle, but like, but it's two of them.
Okay. This lancet shaped diploma. Okay. Okay. So strep pneumoniae, a beta, a sorry, strep pneumoniae, alpha hemolytic gram-positive cocci strep pneumoniae is surrounded by a polysaccharide capsule, which helps it to evade the host immune response. Host immune system, particularly in asplenic patients. Strep pneumoniae is the most common cause of strep pneumonia is the most common cause of community acquired pneumonia in immunocompetent patients. It is also have common cause of otitis media, meningitis, sinusitis, bacteremia. This presentation involves several days of productive cough, chest discomfort, and the shortness of breath, often uh, following upper respiratory tract infection. A patient may have fever, tachycardia, tachypnea. Crackles are hard. Crackles are often heard on auscultation of the lungs, and imaging will show an infiltrate. If an effusion or dense infiltrate is present, as may be the cause with the patient, dullness to percussion may be heard on auscultation. Community acquired pneumonia is treated empirically with a combination of the antibiotic including macrolide, tetracycline, fluoroquinolone, beta-lactams such as cephalosporins are used to treat the strep pneumonia. Vaccines are available to prevent pneumococcal infection in older patients. Okay.
Can you read B and F? VF.
Legionella is a gram-negative rod. It's transmitted primarily through aerosol or from water sources. It is also called Legionnaire's disease, characterized by fever, pneumonia, gastrointestinal symptom. Treatment includes cough. Treatment includes macrolide or fluoroquinolone antibiotics. Legionella is not a community or pneumonia. Staph aureus is a gram-positive cocci, which is known as a wide range of infections such as skin or soft tissue infection, pneumonia, endocarditis, sepsis. However, Staph aureus are more commonly causes secondary pneumonia after viral infection, not community acquired pneumonia. Okay.
How was the pneumonia of Legionella again?
Legionella is hyponatremia, Legionnaire's disease.
Is it?
Like this sheep, SS16 sheep,
Mm-hmm.
uh, they are two couple is doing romance, giving flower, fluoroquinolone, and there is salt, like salting the sodium, like salt throwing in the ocean. That is hyponatremia.
Okay, and it's lobar pneumonia.
Yes, it's a lobar pneumonia.
And strep is also lobar.
Yes, strep is lobar, and in the
Okay.
X-ray, like in the X in this stem, they actually mean the lobar pneumonia because there is percussion,
Mhm.
dullness to percussion on the lower lobe of the left lung. Looks like uh, there is a consolidation over there, isn't it?
Really?
Yes, because there is a percussion note dull. Dull percussion note happens in where? Consolidation.
Okay. Okay. Got it. Mm,
Look at the left lobe of this lung.
like
There
this
is,
one?
yes,
Okay.
there is a consolidation, like looks like a cavitary lesion.
Yeah, kind of looks like a cavitary lesion. Okay. Got it. Next. Previously healthy 15-year-old girl brought to the physician because of a vaginal discharge and abdominal pain for 3 days. She has not had fever or dysuria. Menarche was at 12 years of age and her last menstrual period was a week ago. Sexually active and uses OCPs. Temperature is high, pulse is fine, respiration fine, BP a bit low. Abdominal exam shows normal bowel sounds with mild right lower quadrant tenderness without rebound, masses or hepatosplenomegaly. Pelvic exam shows a friable cervix with a moderate amount of yellow discharge and scan blood. right lower quadrant. There is mild cervical motion tenderness, but no adnexal tenderness of masses. Gram stain of the cervical discharge, hmm, what is happening? Shows gram-negative intracellular diplococci, urine beta ECG is negative. The patient does not want her parents to know that she's ill. Which of the following is the most appropriate course of action?
So it's a minor. So and she has like STD. So we need to treat without the consent of the parent. Okay, minor or any person younger than 18 of age may be tested or treated for STI without parental consent. Though parental consent is required for most medical care, exception include medical care related to STD, sexual activity, STI, contraception, and pregnancy care, substance use, life-threatening medical or psychiatric condition. This physician honor the patient's wish uh, not to inform her parents and instead encourage the patient to discuss this medical issue with her parents. Emancipated minor may also make their own medical decision. This patient likely has PID and causes PID causes caused by Neisseria gonorrhea, gram-negative diplopus. The physician should discuss with her the need for testing for other STIs. Okay, like chlamydia and HIV.
52 men comes to the ED because of swelling of his lips for 5 hours. He has not had difficulty breathing or any other symptoms. 6 hours ago, he ate the Thanksgiving meal, which included turkey, gravy, stuffing, cranberries, sweet potatoes, pear, onions, and pumpkin pie. Before dinner, he ate salmon hors d'oeuvre. He has hypertension and hyperlipidemia, current medication, aspirin, atorvastatin, lisinopril. On arrival, he's not in distress. Vital signs are normal. Exam shows edema of the lips. There is no stridor of wheezing. Results of initial labs are within are fine. In addition to administration of antihistamine, which of the following is the most appropriate next step?
Okay, it's hereditary angioedema due to ACE inhibitor. That's why there is swelling, but there is swelling edema but no chest discomfort, no breathlessness, and no itching, like no urticaria feature. So it is hereditary angioedema due to overproduction of the bradykinin. Okay, next.
You read that one?
Yes.
Okay.
Okay, hereditary angioedema is caused by the autosomal dominant inherited or de novo deficiency in a C1 esterase inhibitor or on a C1 esterase inhibitor, which leads to overactivation of the complement system, and overproduction of the bradykinin A vasodilator. It presents with intermittent episodes of swelling of the skin, intermittent episodes of the swelling of the skin, face, lips, oropharynx, the mucosal lining of the gastrointestinal system. Symptoms depends upon the affected area and include dyspnea secondary to upper airway obstruction, abdominal pain, gastrointestinal distress. Physical examination shows edema and the absence of urticaria, which can help distinguish hereditary angioedema from anaphylactic reaction. Further evaluation would also show decreased C2 and C4 complement concentration in addition to the decreased concentration or activity of the serum C1 esterase inhibitor. Of angioedema commonly self-resolve. Episodes of angioedema commonly self-resolve. However, antihistamine and epinephrine are commonly administered until anaphylaxis is ruled out. If impending airway compromise is suspected, patients must be immediately treated with securement of the airway and administration of plasma derived or recommended C1 inhibitor. Episodes of angioedema can be triggered by trauma, infections, foods, or medications, lisinopril, an AC inhibitor, increase bradykinin concentration as AC is responsible for degradation of the bradykinin inhibitors. Lisinopril should be discontinued in this patient to prevent further increases in serum bradykinin concentration and exacerbation of the spread of edema. Okay,
B, as in boy.
yes. Radio allergosorbent test. Radioallergosorbent test is used to identify the antibody against antigen, although it is no longer commonly used. The absence of urticaria and the use of AC inhibitor make hereditary angioedema more likely than the allergic reaction in this patient. Therefore, RAST would not be the most appropriate step in the evaluation. Okay.
Yeah. Next. 27. Hmm. Woman comes for follow-up exam 8 days after completing a course of amoxicillin for treatment of sinusitis. She has been feeling well, but recently noticed a painful patch in her mouth. Exam shows 1.5 white patch behind the tongue. The patch cannot be scraped off. A photo chaos preparation of the patch of the whatever is shown here.
Is the germ tube in the photo?
Guess so. Where do you see it?
Because candida to happen, the clue in here like white patch of the tongue, but in the candida you cannot scrape the white patch.
Which one is the one you can scrape?
In candida you can scrape the white patch.
You can or you cannot.
You can.
Okay, here it says you cannot.
I don't know why.
Hmm, okay, okay. But
Like
the germ tube, what is the germ tube?
germ tube is the fungal finding, like the black one in the long leaf, the black
Oh,
portion.
like this thing, like this.
Yes.
Okay, okay. I'll read it.
Okay. This is fluconazole diagnosis is candida. I don't know why. Okay, oral candidiasis is classically thick white plaque on the tongue on the buccal means which can be scraped off, but in here they said that cannot be scraped off. In this patient, white patch could not be scraped off, and potassium KOH preparation shows a typical. There is budding yeast, and it is all. Their name is also germ tube. Okay, budding yeast with or without hyphae, with or without hyphae, that is characteristics of Candida albicans. Candidiasis may cause dysphagia, trouble swallowing, or odynophagia, pain with swallowing, especially if Candida esophagitis is present. It is typically caused by infection with Candida albicans. Candida albicans, which is a ubiquitous dimorphic fungus that causes a wide spectrum of clinical disease in the immunocompetent host, including infection of the moist skin folds, intertrigo, vaginal infection, or oral thrush. It is also commonly seen in immunosuppressed individuals. Patients recently treated with antibiotics or patients using corticosteroid inhaler. Patient presenting with mild symptoms typically treated with topical medications such as nystatin, miconazole, clotrimazole when dermal. In this in cases of moderate to severe disease and in this patient or invasive disseminated disease patient can be treated with systemic fluconazole and nystat swish and spit or swish and swallow regimen may also be acceptable. Okay.
You read B and E.
Yes. Amphotericin B can be used in the treatment of oral candidiasis that is severe or and refractory to fluconazole. In this patient, in the treatment of invasive fungal disease. However, the adverse effect profile of amphotericin B is significantly more hazard, significantly more hazardous than that of the fluconazole. So it is not the best first line therapy. In this case, the patient does not have systemic symptoms and systemic symptom and has not failed prior to make fluconazole more acceptable. Okay,
Okay.
Clo- okay.
42 woman comes to the physician for routine health. She received a diagnosis of glomerulonephritis 1 year ago, which was treated with steroids successfully, with resolution of kidney failure and proteinuria. At her last visit 1 month ago, her BP was 110/70, serum creatinine was fine, and urine dipstick was negative for protein and blood. Her only medications are lisinopril and multivitamin. She swims like 2 miles 5 times weekly. She is BMI is fine, pulse is a bit low. BP is fine. Exam, including cardiopulmonary exam, shows no other abnormality. There is no peripheral edema. Labs, believe hemoglobin is fine, urea is fine, creatinine is fine. Urine, protein, 1 plus, RBC none, white blood cell none. Which of the following is the most appropriate next step to stop progression of this patient? Renal insufficiency. She does not have renal insufficiency. Okay.
He has uh, kidney failure previously with resolution of kidney failure and proteinuria. He has glomerulonephritis. From that
But that was, it
one
was
year,
treated fine.
yes, because glomerulonephritis, his kidney is now fine. Okay,
Mm-hmm.
so we need to control the uh, we need to strictly control the pressure as far I guess.
Okay.
Okay. Yes, his BP is nearly normal, 130/86. Okay. But 1 plus protein loss in the urine is this the reason? Okay. Increasing the dose of the lisinopril would be the most appropriate recommendation to decrease the patient's risk for kidney failure. Lisinopril is a AC inhibitor which inhibits angiotensin converting enzyme resulting in decreased production of angiotensin 2 and aldosterone. Angiotensin 2 is a potent vasoconstrictor that directly mediates systemic hypertension via increased sodium reabsorption and increased sodium reabsorption in the kidney tubule. Aldosterone release by the adrenal cortex, vasopressin release leading to fluid retention, increase adrenergic tone, and stimulation of hypothalamic center. Use of AC inhibitor therefore results in decreased blood pressure by the multiple mechanism. This patient's blood pressure is mildly increased and rising compared to prior and increase the doses of AC inhibitor. Uh, Increase the doses of the S inhibitor would address this aspect. Additionally, immunolysis for recurrent proteinuria, the decreased production of angiotensin 2 also results in the decreased production of the angiotensin 2 also results in relative efferent arterial dilatation. This leads to decreased glomerular filtration pressure and decreased glomerular filtration pressure. Intraglomerular this reduction in intraglomerular pressure will reduce damage to the glomerular capillary limit proteinuria, and the decreased production of angiotensin II also results in relative afferent arteriolar dilatation. This leads to decreased glomerular filtration pressure. This reduction in intraglomerular pressure will reduce the damage of the glomerular capillary, limit proteinuria, and decrease the patient's risk for kidney failure. These patients worsening hypertension and increased intraglomerular pressure uh, will both be addressed by increasing the lisinopril doses.
Next. 19-year-old. Oh, yeah. So it was the blood pressure that was increasing. 19-year-old man brought to the physician by his parents because they are worried about his behavior since he dropped out of college 2 months ago. When he came home, he appeared distracted and preoccupied and will not answer the question. He will only say that it is unsafe for him to return to school because his professors had been stealing from him and that the campus police are searching for him for using an experiment. His parents, that was 2 months ago. His parents state that he has always been shy and more of a loner than the other children, but that now he will not even talk to them. He has not had changes in sleep or appetite. He has no history of serious illness, doesn't take medication. His parents report that his maternal cousins take medication for psych problems and has a history of several psych hospitalization, but that they are unaware of the diagnosis. The patient is mildly malodorous and unshaven. Vital signs are normal. He will not cooperate with the full physical exam, but appears to move all four extremities fine. Mental status exam, he is angry, mum- mumbles to himself, and searches his pocket for something. He's not depressed. His speech is normal in rate and rhythm. Which of the following is the most likely diagnosis?
What is your diagnosis?
I guess it's schizophrenia, but when they say that his speech is normal rate and rhythm, I guess
Speech is normal. If speech is rapid and loud, then it goes for bipolar. He
rapid
has
and loud.
hallucination. Psychiatric problem. Where is the clue? Okay.
Hmm.
So according to the DSM-5, schizophrenia has at least two out of the five feature, at least two of the five symptoms. Delusion, paranoid belief, hallucination. These are on a speech. These are on his behavior. And negative symptom like flat effect, apathy, alogia. Many patients also illustrate prodromal periods of strange behavior and social withdrawal to meet the diagnostic criteria. To meet the diagnostic criteria in this patient must demonstrate functional deficit and the total duration of symptoms must exceed 6 months. Mental status examination commonly shows poor hygiene secondary to the negative symptoms and evidence of internal stimulation secondary to secondary to where secondary to negative symptoms and evidence of internal stimulation like speaking to hallucination rather than external stimuli such as the other people distractibility uh, distractibility secondary to hallucination, a family history of schizophrenia or bipolar disorder, or a childhood history of anxiety are common. Treatment requires antipsychotic medication.
Can you read A and C?
Yes, bipolar disorder refers to manic episodes in a patient with underlying bipolar disorder. Bipolar consists of episodes of mania or hypomania as well as depression. Manic episodes are characterized by persistently elevated mood with increased energy, increased self-esteem, decreased sleep or pressure speech, racing, thought, distractibility, psychomotor agitation, hyperactivity, disinhibition or impulsivity. Psychosis, grandiose delusion, or hallucination is common. However, negative symptoms are common. Further, this patient does not endorse mood changes, sleep changes, increased energy, hyperactivity, deep, demonstrate pressure, speech, demonstrate pressure, speech on examination, which would be expected if bipolar disorder were present. A and C. Major
Mm-hmm.
depressive disorder with psychotic feature. Major depressive disorder with psychotic feature includes two or more weeks depressive symptoms, depressed mood, psychomotor slowing, anhedonia, decreased energy, decreased energy, mm, and changes in the sleep and appetite, and psychotic symptoms uh, occur concurrently. The psychotic symptoms are typically mood congruent delusion of guilt and can be conceptualized as secondary to depression, paranoid delusion, disorganized behavior. Negative symptoms are more consistent with psychotic disorder. This patient does not demonstrate depressed mood or neurovegetative symptoms consistent with major depressive disorder. Okay.
Okay.
Okay. Can
Next.
we take 2 minute break?
Yeah, yeah.
I'm coming.
A 3-man history of personality changes. She says that he has become withdrawn and is no longer interested in socializing with friends and family. At the restaurant last night, he sexually groped a waitress. The patient has no history of serious illness, doesn't take medication. Vital signs are normal, physical exam normal, neurologic exam normal, mental status exam he has a blunted affect and described his mood as fine. He recalls 2 out of 3 objects after 5 minutes. He makes no errors when performing serious 7. Serum study shows a TSH concentration of 3.8 to 3.8. T4 concentration is 5 and T3 concentration, where are these? TSH is fine. T4
Is normal,
is normal. Wait,
almost
is it?
normal.
Yeah, it's normal. It's normal. It's 5. Wait, yeah. And then T3 is, where is T3? Right here. 1. Okay, it's normal. Results, although the labs are normal. An MRI of the brain shows focal atrophy of the frontal and temporal lobe. Which of the following is the most appropriate step in management?
So it's frontotemporal dementia. Okay. So uh, in frontotemporal dementia is the neurodegenerative disorder that most commonly begins after the age 50 but can start as late as 80 years. As seen in this patient, mm, there are no disease modifying treatments for FTD. Irritability and agitation may be managed with serotonergic medication or atypical antipsychotics such as risperidone. There are two distinct subtypes of FTD: behavioral variant and primary progressive aphasia. Behavioral variant is characterized by personality changes secondary to frontal lobe degeneration. Patients may present with disinhibition, sexual transgressiveness, apathy, hyperorality. Primary progressive aphasia (FTD) is characterized by progressive language disturbance secondary to temporal lobe degeneration. The diagnosis of the FTD is primarily clinical through neuroimaging findings and of frontal and temporal lobe degeneration are supportive. Okay.
Okay, next. 24 woman comes to the office because of a lump in her right breast that her sexual partner first noticed 2 months ago. The patient has no history of serious illness and takes no medication. Maternal aunt was diagnosed with ovarian cancer at 40. 5, a physical exam of the patient shows a 3 centimeter fluctuant, mildly tender, smooth mass in the lower outer quadrant of the right breast. Physical exam no abnormality, which the most appropriate next step in diagnosis.
Okay, it's ultrasonography. The premenopausal patient with a large tender fluctuant lesion most likely has breast cysts. Breast cysts are benign lesions that may be seen in isolation or as a part of a fibrocystic disease. They may also be hormonally responsive and fluctuate in size during menses. However, thorough evaluation is necessary for any patient that presents with a breast mass, as these can be first presenting sign of breast cancer, the most common non-dermatologic cancer in women. The evaluation This evaluation should include the evaluation should include through history, including family history and physical examination. Physical examination typically shows a smooth, rubbery, freely mobile mass without coexisting skin changes, lymphadenopathy, or nipple discharge in benign lesion. In contrast, malignant lesions often present with irregular, firm, adherent mass and one or more of the concurrent sign. Further evaluation includes diagnostic imaging with either ultrasonography if under age 35 years or mammography if over 35 years. If ultrasonography in this patient shows a cystic lesion, fine needle aspiration should be evaluation. Fine needle aspiration should be completed to see the mass. Evaluation include diagnostic imaging, either ultrasonography or mammography. Okay, sorry. Fine needle aspiration should be completed to see if the mass resolves and to treat the patient's associated symptom. If cyst disappears, no further treatment is warranted. If it does not, core needle biopsy should be performed to rule out the malignancy.
Can
Okay,
you read D?
which one?
D as in dog.
Uh, Re-examination after next means would be would not be appropriate. While breast cysts can fluctuate in size in relation to the menstrual cycle, any patient that presents with a breast mass any patient presents with a breast mass a thorough evaluation to rule out should have a thorough evaluation to rule out malignancy, to decrease the morbidity and mortality associated with delayed diagnosis. This patient should undergo further testing with ultrasonography to ensure her lesion is benign, and possibly fine needle aspiration to manage her symptoms.
So is it 30 or 35? Because I think on you what it says less than 30 ultrasound, 30 or more mammography. Here is 35.
Yes,
So is it
there is another box
okay?
like, okay, I'm seeing the breast cyst.
For the ultrasound versus mammogram, I felt like I thought it was 30. So it's
Isn't it
35 now.
30?
Yeah, I thought it was 30, but here it says 35. So I don't know if it has changed or something. Okay. Okay, so we keep it at 30.
Mm, I think so.
Okay. Next.
I'm looking
50.
for that chart. Okay.
58 man comes to office because of a 1 day history of progressive
Okay,
weakness.
look, in nbme in the usml inner circle they actually told
Mhm.
you. Okay, I'm sharing my screen and you may be.
Okay.
Okay, can you see my screen?
Yes.
So palpable breast mass like the cyst, age less than 30, ultrasonogram, Ultrasonogram with or without mammogram, but more than 30 mammogram first, with or without ultrasound.
Okay, so it's
Simple
30.
cyst, needle aspiration. Complex cyst, image guided biopsy. And in NBME, they are saying that it is less than 35. Ultrasonogram is less than 35. Got it?
So what do we use, the 30 or the 35?
We should remember it. It is the reality.
The 30.
Uh, in the operative field, like in the surgical field, they actually use it.
You which one? The 30.
30, yes, yes.
Okay.
Like the breast mass before 30 or within 30, we actually use ultrasonogram first. If it is very suspicious, then we actually go for mammography. Usually do not go for mammography in the early 30s because breast architecture may be distorted due to this test.
Okay. Got it. Next. Let me share my
Okay.
screen. Okay. 58 men comes to office because of one day history of progressive weakness of the left leg. He now catches his left great toe on his carpet when he walks. He has not sustained any injury or had any changes in his activity, no fever, chills, bowel or bladder incontinence. He has hypertension, coronary artery disease, type 2 diabetes, sorry, type 1 diabetes, medication, metropol, amlodipine, insulin. His daily finger stick blood glucose concentration range from 100 to 120, so it's fine. He's alert and fully oriented, vital signs normal. Cranial nerves normal. There is no tenderness to palpation of the low back. Range of motion is decreased in on lateral bending. Result of muscle strength are hip. Everything is fine in the hip. Knee. Everything is fine in the knee. Ankle. Everything is fine in the ankle. Extensor hallucis is longest. That's where the issues start. The left one is 3 out of 5, and the right one is 5 out of 5. Tibialis anterior, left one is 3 out of 5, right one is fine. And peroneus brevis, left one is 3 out of 5, and the other one is fine. Passive range of motion of the ankles is full. No pain is elicited on ankle palpation bilaterally. Patellar and Achilles deep tendon reflexes are fine. Dorsalis pedis pulses are 1 plus in the lower extremity. Steppage gait is present. Which of the following is the most likely explanation for these clinical findings?
Okay, it's peroneal neuropathy. Peroneal mononeuropathy can be a complication of diabetes mellitus that affects the peroneal nerve. That affects the peroneal nerve. The peroneal nerve is responsible for ankle dorsiflexion as well as eversion. Peroneal, we know that peroneal everse and dorsiflex, PED. So the peroneal is responsible for ankle dorsiflexion and eversion. The peroneal mononeuropathy results in foot drop. Other cause of peroneal mononeuropathy are as trauma, nerve transection, fibular head fracture, as well as prolonged pressure on the nerve. Poorly controlled diabetes mellitus is a primary risk factor for the development of diabetes mononeuritis. A diagnosis of peroneal mononeuropathy is typically based on the patient's clinical presentation. Additional testing such as nerve conduction studies may be done to confirm the diagnosis. Nerve conduction study can be done to confirm the diagnosis but are often not necessary. Treatment of peroneal mononeuropathy include physical therapy, foot and ankle exercises, orthotic devices to support the foot. For patients with a history of type 1 diabetes mellitus, progressive leg weakness and a physical examination consistent with impairment of the peroneal nerve, peroneal mononeuropathy is the most likely explanation for these clinical findings. Okay,
Can you read A?
yes. Autonomic neuropathy is a type of peripheral neuropathy that affects autonomic nervous system. This typically results in fluctuation in pulse, blood pressure, digestion, control of micturition, and sweat production. Though diabetic mellitus is a risk factor for the development of autonomic neuropathy, the patient has no signs and symptoms of autonomic dysfunction as he has control of his bowel and bladder, and vital signs are within normal limits.
Okay. 52 women with metastatic breast cancer comes to the physician for follow-up. She has a 6-month history of bone pain in the lower back and left hip that has been unresponsive to codeine, 60 milligrams every 4 hours, and ibuprofen, 800 milligrams every 8 hours. 6 years ago, she underwent modified radical mastectomy. 1 year ago, she was diagnosed with metastasis to the liver and bone. She's currently receiving chemo. Her pulse is it's fine, high, a bit high. Respiration normal, BP high. Abdominal exam shows enlarged tender liver. There is tenderness to percussion over the T3, T6. Her serum alphos activity is 280, which I think is high. Which of the following is the most appropriate next step for the patient pain control? Let me see alphos. Yeah, it's high.
Okay. Opioids are the potent analgesic that reduce the sensation of uh, mu kappa and delta receptor agonism through the central and peripheral nervous systems. Despite their potential misuse, opioid agonists are effective for the management of pain such as perioperative period, following trauma, and in the setting of cancer, which can produce severe chronic pain and is that is intractable to other modalities. Treatment with opioids typically employs mu-opioid receptor agonists such as morphine, oxycodone, hydromorphone, fentanyl, and methadone. Dose titration is often necessary after beginning of initial therapy. Oral opioids are typically administered on a fixed scheduled dose. Breakthrough or progressive pain can be treated by increasing the scheduled dose, usually at least 25%. The percentage increase in doses is informed by the severity of the pain and the managed severity of the pain and assessment of their comorbidities and risk factor for overdose. Patients with uncontrolled pain on high doses short-acting opioids such as this patient may benefit from transdermal patches, sustained release formulation such as sustained release morphine. So for first short-acting opioid is tried, then if pain is not controlled, go for sustained release long-acting like morphine.
Usually, they set to increase until the maximum dose and then switch to. But I guess this is the maximum dose, the 60 for every 4 hours. Because usually it will say to increase to the maximum dose. But okay,
Okay.
okay. What's the 25% of the, if we increase 25%, what would that be of 60?
Sorry.
Like you see how it says that by increasing the scheduled dose usually by 25%. So if we increase by 25%, what would that be? If we increase the 60 milligrams by 25%, what would that be?
Codeine. I don't know.
Mm, okay. Okay. Never mind. Okay.
4 hour is
Next.
the maximum, isn't it? Is there anything like we need to give the drug to get out of our system? That's why we need some
Mhm.
time interval.
Okay. Okay. Next. 47 men comes to the physician because of a 6-month history of progressive shortness of breath on exertion and fatigue. He has type 2 diabetes, hypertension, OSA, GERD, hypercholesterolemia, medications, metformin, benzapril, enazepryl, famotidine, atorvastatin. He uses CPAP. He does not smoke or drink alcohol. BMI is super high. Temperature is fine. Pulse fine. Respiration fine. BP 138/86. Pulse oximetry is 86. Exam shows mild circumaural cyanosis. Pulmonary exam is fine. Cardiac exam, there is a split S2 and prominent P2. No murmurs, um, gallops or rubs are heard. Abdominal exam shows no hepatomegaly or ascites. There is 2 plus vertebral and ankle edema bilaterally. Which of the following is most likely to be decreased in this patient? Too much going on.
So palpable P2, one of the feature of pulmonary hypertension, like split S2 and prominent P2. We actually tell that palpable P2 is for pulmonary hypertension, isn't it?
Table P2 is for pulmonary. Oh, okay.
That is one clue. And apart from that, I don't have any. Okay. So
Okay.
pulmonary hypertension can be primary genetic mutation causing smooth muscle hypertrophy or increased pulmonary vascular resistance, or uh, secondary OSA, COPD, chronic venous thromboembolic disease, pulmonary fibrosis, and left heart failure. It presents with signs of right heart failure, including dependent edema, right jugular venous distension, and hepatic congestion. Examination typically shows precordial heave, and delayed or loud pulmonic second heart sound, and tricuspid or pulmonary insufficiency as a result of chronic hypertrophy of the right heart. Treatment depends on Treatment depends on the cause of the pulmonary hypertension. In this case, the cause is most likely secondary due to diagnosis of the obesity, obstructive sleep apnea. Due to diagnosis of the obesity, obstructive sleep apnea, treatment should focus on weight loss to improve the patient's obstructive sleep apnea of improving his in the hope of improving his pulmonary hypertension, because the pulmonary hypertension, there is decreased blood flow through the pulmonary vasculature, resulting in lower left atrial filling pressure and ultimately lower left ventricular and diastolic pressure.
You read B.
Yes, intrapulmonary shunt, pulmonary arterial pressure, and pulmonary vascular resistance would all be increased in a patient with pulmonary hypertension, as the pressure and the resistance between the transmitting parenchymal pulmonary vessels increases with the respect of shunting vessels. A greater fraction of shunted blood flow could occur in the pulmonary hypertension. Pulmonary vascular resistance is generally increased in pulmonary hypertension. As a result, the pulmonary artery pressure must increase to overcome such a resistance and permit pulmonary blood flow. In chronic hypoxia, obstructive sleep apnea, obesity, hypermobility, there is a resultant increase in the pulmonary vascular resistance, pulmonary arterial pressure, and intrapulmonary shunting.
I don't understand the intrapulmonary
Yes,
something.
I don't
What?
understand either.
Oh.
Okay. One thing we can assume that, so he has obstructive sleep apnea. He is using OSS, so it is a secondary cause of pulmonary hypertension. That is
Mm-hmm.
that is the thing. And pulmonary. and pulmonary hypertension is confirmed by there is palpable P2 and a
Mm-hmm.
loud. So these indicates for he has pulmonary hypertension. Okay. Now, why left ventricular end diastolic pressure? No, why not the other three options? That is the thing.
No, I get why left ventricular end diastolic pressure. I just didn't get why the intrapulmonary shunt is decreased. Okay, because intrapulmonary shunt. Okay, where do you see intrapulmonary shunt in what?
Intrapulmonary shunt,
Uh,
the shunt between the pulmonary vessels.
yeah, also the lamp doesn't participate in proper gas exchange. Okay, blood goes to the lungs and doesn't participate in gas exchange. Okay, it bypasses the alveolar and enters the left side of the heart. Oh, okay, 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 okay. I
I don't
think I
get
got
it.
it. Okay. Example,
What they are trying to mean,
like the blood goes to the lungs, but
but
it
do not
doesn't
go
get
for gas
oxygenated.
exchange.
So, like, kind of like the, where do you see it?
Like from pulmonary artery, the blood goes to the lung. Then
Mm-hmm.
the gas exchange happen, and from pulmonary and from the lungs, blood actually goes to the left atrium with via pulmonary valve. So these like pulmonary artery does not uh, take part in gas exchange when they enter into the lung.
Mm-hmm. Doesn't like in pulmonary edema, like the blood goes there, but the alveoli is full of water or whatever, so the blood just comes out and doesn't get oxygenated, kind of thing.
Okay.
You see, yeah. So here they said that will be increased, I guess that will increase the intrapulmonary shunting. So here, I guess that's not what is happening.
Okay. Look at the question again.
Mm-hmm.
Which of the following is most likely to be decreased?
To be
Intra
decreased.
intrapulmonary shunt will be increased because
Increase. Yes, you
and
get it. You said
pulmonary
it.
artery pressure and pulmonary vascular resistance will be increased because as it is a pulmonary hypertension, so this shunt and artery pressure and venous pressure will be increased. Okay.
Yes, because the blood is going, but it's difficult that for the blood to get oxygen because there is
Yes.
hypertension. Got it. Got it. Got it. Okay, makes sense. 27 men admitted to the hospital for treatment of injuries sustained in a motor vehicle collision. He states that he was feeling out of it at the time of the collision but feels better now. He's employed as a truck driver. During the past 6 months, he has had three prior collisions but sustained only minor bruises and abrasions. He attributes the collisions to difficulty concentrating, especially when he drives long distances without eating. He has not had chest pain. He has no history of serious illness, no medication, no alcohol, no drugs. He's alert and fully oriented. Exam shows no abnormalities except for tenderness over the left shoulder and muscles of the left upper extremity. Finger blood glucose is like super low. Results of lab studies are otherwise normal. Which of the following is the most appropriate next step in diagnosis?
So what is the diagnosis?
Some kind of hypoglycemia. I don't know why.
Okay. So the most appropriate next step is the diagnosis of 72-hour fasting measurement, 72-hour fasting measurement of serum insulin and glucose. How it is done? 72-hour fasting measurement of serum insulin and glucose concentration when there are concerns for insulinoma.
Oh, insulin. So 72 hours without eating.
Is it possible?
I don't know. Or without eating gluten. Okay, I don't know.
Okay, what kind of test it is, I don't know.
I don't know.
Okay, insulinoma are a tumor of the pancreatic, rare tumor of the pancreatic islet cells that inappropriately produce excess amount of insulin, results in hypoglycemia. Signs and symptoms of an insulinoma include confusion and difficulty concentrating, sweating, fatigue, weakness, fainting because of hypoglycemia. Symptoms often precipitated either by a period of fasting, as seen in this patient when he drives long distance without eating, or by strenuous exercise. Acute management of hypoglycemia is the paramount for these patients to avoid more serious complications such as seizures or fainting. Insulinoma are generally small and Insulinoma are generally small and benign, but have been found on occasion to grow larger to metastasize. Diagnosis may be made by 72-hour fasting insulin and glucose level, C-peptide concentration, as well as imaging studies, CT scan or MRI or ultrasonography to locate the size of the tumor. Treatment is surgical removal, though dioxide can though dioxide can be used to decrease the insulin production in the interim.
Can you grade B and C?
Yes, I'm very confused how this 72-hour fasting serum insulin and glucose is done. Okay, measurement of measurement of serum ACTH is used when there is concern for adrenal insufficiency, Addison's disease, Cushing disease, ectopic ACTH production. It is usually it is also causes in case of it is usually causes Addison's disease can present with hypoglycemia but characteristically presents with hyperpigmentation of the skin, weight loss, decreased appetite, low blood pressure. In this patient who has a correlation of his symptoms with periods of prolonged fasting, ACTH related disorder are less likely. Glucose tolerance test would be appropriate in patients where there is concern for diabetes mellitus. This test is used to assess for patients' response to a glucose bolus to determine if insulin resistance is present. In this patient, episodic hypoglycemia. In this patient with episodic hypoglycemia, it is unlikely that a glucose tolerance test would show the underlying pathology of the insulinoma. Okay,
Level, level test. Fasting hypoglycemia test used to then blah 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 weapon blah 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 blah. It involves monitoring blood glucose and insulin level during a prolonged fast. The test typically which the patient is not allowed to eat or drink anything except water. Yeah, 72 hours without eating or drinking, and at least he can drink water. And I've never
you do
seen this.
this test and give me the result.
I've never like this really like the first time I hear about the test. The patient is admitted to the hospital and instructed to
I
fast for
think that
7.
this test will kill the patient, not the
Yeah.
insulinoma. It
It
is
says that the fast, you see, it says the fast is discontinuous or is stopped if the patient experiences symptoms of hypoglycemia. Yeah. Or if the blood sugar drops below, like, yeah. So I don't think it goes all the way to 3 days. I think that once they start seeing that it goes too low, like they stop it.
okay.
It's it.
Like strict monitoring is necessary.
Yeah, he's admitted to the hospital. Yeah,
Yes,
yeah, yeah. He's doing it at the hospital for 72 hours. Yeah.
yes.
Next. 1 month old newborn is brought to the physician for his well child visit. 1 month. He is exclusively breastfed, growth and developmental are age appropriate. Exam shows no abnormality, routine newborn screening is positive for sickle cell disease. Which of the following is the most appropriate recommendation to prevent morbidity from this condition? Mm.
Okay. This is like daily oral penicillin. I think that in sickle cell there is a box where it has said that uh, uh, daily penicillin up to age 5.
Mm-hmm.
We have read that thing. Okay.
Mm-hmm.
Sickle cell disease can lead to functional asplenia, secondary to chronic vaso-occlusion and infarction. The spleen removes the pathogens and the infected cell by mechanical filtration in the sinusoid through phagocytes by the splenic macrophage. Additionally, the spleen houses the immunoglobulin. Additionally, the spleen houses the immunoglobulin producing B lymphocyte. The spleen plays an important role in the clearance of encapsulated pathogens such as Haemophilus influenzae, Neisseria meningitis, Strep pneumoniae, Pseudomonas aeruginosa, and Klebsiella pneumoniae, among others. Thus, patients lacking a functional spleen are at risk for severe infection or sepsis. With encapsulated bacteria, vaccination against these organisms when available is vital to minimize the risk of infection. In children, in childhood, antibiotic prophylaxis against these organisms is indicated typically with penicillin and amoxicillin. Okay.
Okay. Next. 25 men comes to the office for routine maintenance. He has no history of serious illness, doesn't take medication. He smoked a pack of cigarettes for 7 years. Blood pressure is super high. Grade 3 out of 6, harsh mid-systolic crescendo decrescendo murmur. Heard at best at the upper left sternal border with radiation to the neck. The murmur is louder with Valsalva maneuver. The point of maximal impulse is at the anterior axillary line in the fifth intercostal space. ECG is shown. Which of the following is the cause of the patient murmur?
Okay, ECG shows left ventricular hypertrophy. Uh, Left ventricular hypertrophy can be diagnosed like S in V1 and R in V5 or V6. If
Is V1.
and R in V5 or V6, if it is more than 35, then it is left ventricular hypertrophy. In V6 lead, look at 5, 10, 15, 20, 30, 35. Only the lead V6 is near about 35. So it is left ventricular hypertrophy. The like the lower part of the V6. You got
Mm-hmm.
my point, what I am talking about.
No.
Not this one.
Mm.
S in V1 and R in V5 or V6. The R wave is the lower one.
QR. Wait. PQR. It will be this one, right?
No, it is not this one.
Mm.
The left one, the bigger one.
This one.
No, no, the
Wait.
left side. You search the Gemini
Mm-hmm.
and you will get the answer. What I am talking about.
You say
The,
S in V1.
yes, S in V1 and R in V5 or V6.
In V5, V6.
The the you should look at the top one like this one. Okay,
What do you?
I'm sharing my screen. Then you will understand. Oh, so this okay. Now I can see your screen.
Can you see it?
Yes.
Okay.
So the patient's presentation is consistent with hypertrophic obstructive cardiomyopathy, which is which classically presents with dyspnea, chest pain, which classically presents with dyspnea, chest pain, syncope, or sudden cardiac death in an exercising young adult with potential family history of similar event. Physical examination findings include a laterally displaced point of maximum impulse with a harsh mid-systolic murmur, loudest in the lower loudest in the lower sternal border, a which is quieter with increased preload and afterload, and louder with decreased venous rate in Valsalva maneuver. It is secondary to hypertrophy of the interventricular septum, which can be seen on echocardiography. The ECG has been the ECG may show left ventricular hypertrophy with a large amplitude S wave in the right-sided precordial lead with increased R wave in the amplitude of the V6. In addition, left ventricular outflow tract obstruction with the walls of the left ventricle are stiff and non-compliant, which impairs the feelings of the chamber during diastole. Cardiac output decreases, which becomes more pronounced with tachycardia due to decreased diastolic filling. Medication that increase diastolic filling by reducing the heart rate, such as beta antagonist, or non-dihydropyridine calcium channel blocker, are the mainstay of the treatment. Okay.
Okay. Next. 29 women, no, primigravida Vietnamese woman at 6 weeks gestation, come to the office for first prenatal visit. She has no history of serious illness. Only medication is prenatal vitamin. The uterus is consistent in size with 6 weeks. Lab shows hemoglobin concentration is low and MCV is low. The serum ferritin concentration is 72. Which of the following is the most appropriate next
Serum
step?
ferritin is 42.
42, let me see, is normal. Which of the following is the most appropriate next step?
So
So since
low hemoglobin and
MCV is low, but ferritin is normal.
normal. So hemoglobin electrophoresis should be done to look for other cause of microcytic hypochromic anemia, isn't it?
Okay. Mm-hmm.
Okay. Hemoglobin electrophoresis is the next step in evaluation for this. Hemoglobin electrophoresis is the next step for these patients. For if is the next step in the evaluation for this pregnant patient at an early gestational age who has microcytic anemia with normal ferritin concentration, while mild decreased hemoglobin MCB, while mild decreased hemoglobin common in the pregnancy secondary to physiologic increase in the plasma volume. A hemoglobin concentration less than 10.5 is considered abnormal. A hemoglobin concentration less than 10.5 is abnormal and should be evaluated. So hemoglobin concentration less than 10.5 is considered abnormal and should be evaluated. Microcytosis is defined as MCB less than 80 and can be iron deficiency, anemia of chronic disease, thalassemia. Another common other rare cause of iron deficiency, she has normal ferritin. Similarly, anemia of chronic disease presents with normal to high ferritin low iron concentration in the setting of chronic inflammation. Low iron thalassemia is a genetic hemoglobinopathy that causes hemolytic anemia, extramedullary hematopoiesis, extramedullary hematopoiesis, hemoglobin electrophoresis can be used to assess thalassemia. Distinguishing between alpha thalassemia and beta thalassemia would be the most appropriate step in testing. Alpha thalassemia is more common in women of Asian descent. Diagnosed thalassemia may have implication for both mother and the fetus. Okay.
52 women brought to the office by her husband for evaluation of mild aphasia and change in her personality. CT scan of the head discloses 3 centimeter mass in the left temporal lobe and 5 centimeter mass in the right frontal lobe. She has smoked one pack of cigarettes for 30 years. Chest X-ray is reported as showing 2 centimeter speculated mass in the left subapical region. The radiologist calls the physician and says that the lesion was present on her prior chest X-ray done 10 months ago. Which of the following is the most appropriate next step in management?
Inform the radiologist of your possibility to inform the patient and her family of the current and the previous. What does it mean? Okay. Physicians have ethical obligation to disclose medical errors expeditiously. In cases where a provider with no patient contact makes an error and a member of patient's current care team should disclose the error, the disclosure should include ad- admitting there was an error, describing the details and the consequence of the error, apologizing rather than stating regret, explaining the next step to prevent further errors, and eliciting questions from the patient. Apologizing should include fully acknowledging a mistake and its effect on the patient. I'm so sorry we missed the lung mass on your chest x-ray. I feel terrible about the position we have put you in. Disclosing mistakes promotes a culture of transparency and helps to prevent future mistakes. Further, one study showed that increased disclosure rate decreased the rate of medical malpractice claim. Many patients prevent information from physicians' apology from being included in a malpractice lawsuit. Okay.
Okay. Next,
Yes.
for 24 female African American comes to the office because of a 2 week history of progressive bilateral hearing loss. She says that during the past 3 months, she also has had ringing in her ears. She has asthma, hypothyroidism, history of recurrent ear infections in childhood, current medication, inhaled albuterol as needed, and levothyroxine. Mother and one of her 5 siblings are deaf. The patient works as a bartender. BMI is normal, temperature is normal, pulse normal, respiration normal, BP bit high. On exam, the tympanic membranes cannot be observed because impacted cerumen. The remainder of the physical is fine. Which of the following factors in this patient history most strongly indicates poor prognosis?
Okay, a family history of hearing loss most strongly indicate a poor prognosis in this patient. Hereditary hearing loss may present at birth, in infancy, or later during adulthood, and may occur as a result of variety of genetic factors leading to either conductive or sensorineural hearing loss involving the external ear and the ossicle or the cochlea, the auditory nerve respectively. Both syndromic and non-syndromic forms of both syndromic and non-syndromic forms of hereditary hearing loss may occur depending on whether the organ system malformations or dysfunctions are present. Hereditary hearing loss may be inherited in autosomal recessive dominant or X-linked pattern, although autosomal recessive inheritance is the most common. Is the most hearing is often progressive and may worsen over time, carrying a worse prognosis than other forms of hearing loss, in which treatment availability, avoidance of risk factor may modify the patient course. Evaluation consists of general physical examination and audiometry testing, as well as genetic testing in this patient suspected of hearing loss. CT scan of the temporal bone may be indicated in this patient with otherwise unexplained hearing loss. Hearing aids or cochlear implants may be helpful for audiologic rehabilitation in some patient. Genetic counseling should be offered. Okay.
You read D and E.
B and E.
D as in dog. D and
Okay.
E. Mhm.
History of serous otitis media is incorrect. Serous otitis media commonly manifests as sequelae of upper respiratory tract infection with evidence of middle ear infection and the absence of middle ear inflammatory findings. Dysfunction of the eustachian tube is the most common underlying cause. Most cases are self-limited and carry a favorable prognosis. Tinnitus is strongly associated with sensorineural hearing loss but does not carry a prognostic significance. The presence or severity of the tinnitus do not typically correlate with the severity or progression of hearing loss. Further, tinnitus severity may fluctuate over time and may improve with treatment of the underlying cause of hearing loss. Okay.
Okay. Next. 52 Chinese American woman returns to the office because of a 3-month history of heartburn. The patient has type 2 diabetes, pernicious anemia. She also has cholelithiasis, for which she has refused surgical treatment. Medication, metformin, atorvastatin, monthly injections of B12. A1C obtained 30 days ago was high, 7.2. Family history is significant for colon cancer in 2 first-degree relatives. Asian is BMI is high. Which of the following historical findings is the strongest risk factor for gastric cancer?
Okay. A family his sorry. Patients with gastric carcinoma often minimally symptomatic until developing advanced disease. The most common symptoms include weight loss, abdominal pain, which can be vague or located in the epigastric region. Gastric carcinoma may occasionally be associated with paraneoplastic syndrome, such as laser-trillet sign. The presence of diffuse seborrheic keratosis, hypercoagulable state membranous nephropathy, microangiopathic hemolytic anemia. Risk factor for gastric cancer include family history of the gastric cancer, chronic Helicobacter pylori infection, chronic gastritis, pernicious anemia, chronic ingestion of salt and salt preserved foods, obesity, uh, smoking and exposure to N-nitroso compound through diet, tobacco smoking, environmental exposure. Initial imaging for diagnosis is CT scan of the abdomen. CT initial imaging of the diagnosis is CT scan of the abdomen with contrast because patients are often present with advanced disease. Radiation therapy and chemotherapy are often required as surgical resection may be curative. For this patient, pernicious anemia is the strongest risk factor for developing gastric carcinoma.
Can you repeat?
Yes, family history of colon cancer is a risk factor for developing colon cancer. By contrast, family history of gastric cancer is a risk factor for developing gastric
Oh,
carcinoma. I thought the family history of colon cancer.
oh Lord. Okay. I wrote, okay, colon and gastric. Okay. I get it.
Colon for colon, gastric for gastric.
Okay.
Okay,
Okay. Let's stop here. I
yes,
will see you tomorrow.
okay.
Thank you.